Hi guys, in this video we will be learning about myopia, that is short-sightedness. So we will learn myopia under 5 columns: definition, clinical types, clinical features, complications and management. Coming to the definition and etiology. So what is this myopia? It is that when a parallel right ray from the infinity focus in front of the neurosensory retina, provided that the accommodation is at rest. So parallel rays from the infinity should focus in front of the neurosensory retina. It should not reach up to the retina. That is myopia. Coming to the etiological classification, remember it by ACIP. What is ACIP? Axial myopia, curvature myopia, index myopia, positional myopia and accommodative myopia. Axial myopia is the most common type of myopia where we can see increased and AP axial length, that is anteroposterior axial length will be increased, and we have to remember that every 1 millimeter increase in this axial length will cause -3 diopter myopia. So that is axial myopia. We can see that the axial length is increased, 1 millimeter increase will give 3 diopter myopia. Coming to curvature myopia, here we can see the cornea or the lens has become steeper. So it should have a curvature like this. But what happens is the curvature will decrease. So it will be like this or something, such that 1 millimeter decrease will give to -6 diopter. So this is mainly seen in what our keratoconus. So that is curvature myopia. Index myopia is due to the increased lens refractive index. So in the cataract, nuclear sclerosis, what happens? The refractive index of the lens increases and that will give rise to index myopia. And here is the condition where we can see second sight, that is, a person can read near vision or can read the books without the presbyopic glasses. But we have to remember that it is a temporary condition. So that is index myopia. Positional myopia means it is due to the anterior displacement of the lens. So the lens will displace anteriorly, so it will focus before the neurosensory retina. This is seen in trauma and all. Then accommodative, it is due to ciliary spasm. That is our pseudomyopia. So to intense ciliary spasm, the lens will focus it before the neurosensory retina. So this was the etiological classification, ACIP. Now coming to the clinical types, there are 2 types: simple myopia and pathological myopia. Simple myopia is also known as school myopia. It is actually a physiological error in the normal developmental variation. Actually, it is a developmental variation. It is seen in 5 to 10 years of children and usually stabilizes by approximately 20 years. There will be a maximum error of 6 diopter. There will be not more than 6 diopter. And when we look at the fundus, they will be healthy. While coming to the pathological myopia, it is actually progressive, while the school myopia stabilized at 20 years of age. But here it will be progressive. Now it can be hereditary. The error will be more than 6 diopter. And here we can see rapid axial elongation. Okay, axial elongation more than 26 millimeter can be seen. And also degenerative posterior segment changes can also be seen, which we will study now. So degenerative posterior segment changes, while here the fundus was healthy. Now coming to the symptoms, there are common symptom is defective distant vision, and the patient half shuts the eye for stereotypic slit effect, that is to increase the clarity. So there is be gradual progressive decrease in vision, that will be painless distance defective vision. Now pathological myopia can present with floaters, flashes and night blindness. Okay, this is not seen in simple myopia. Only pathological myopia presents with floaters, flashes and night blindness. Coming to the sign, in anterior segment, we can see prominent eyeballs. Their eyeballs will be prominent. They will have deep anterior chamber. Why? Eyeballs are prominent, so they will have deep anterior chamber, and also large and sluggish pupil. So their pupil will be large and also sluggish pupil. On torchlight examination, they will not constrict fastly. So that will be a sluggish pupil, deep anterior chamber and elongated or prominent eyeball. Now coming to posterior segment. So we studied that in pathological myopia there are degenerative posterior segment changes. What are the posterior segment changes? There can be myopic crescent. What is myopic crescent? That is the choroid pulling the optic disc. So choroid will pull the optic disc and there will be a myopic crescent seen. Then we can see trigoid fungus. What is trigoid fundus? It is actually a tessellated appearance due to thin retinal pigmentary epithelium. So on axial elongation, the retinal pigmentary epithelium will get thinned. So there will be a tessellated appearance, and that is known as tigroid fundus. Then there is posterior staphyloma, that is due to scleral ectasia in the posterior pole. The sclera in the posterior pole get ectasia, and that will result in posterior staphyloma. Then we can see Foster first spot. It is actually due to macular hemorrhage due to subretinal neovascularization. Macular hemorrhage result in Foster first spot. Then we can see degenerations like lattice degeneration and cystoid degeneration. So what are the posterior segment changes? Myopic crescent, tigroid fundus, posterior staphyloma, Foster first spot, and peripheral degeneration like lattice and cystoid. Now coming to the complication, there can be retinal detachment. Which retinal detachment? Rhegmatogenous retinal detachment. There can be complicated cataract, mainly posterior subcapsular cataract, vitreous hemorrhage, and choroid neovascularization. So these are the complications: rhegmatogenous retinal detachment, complicated cataract, vitreal hemorrhage, and choroidal neovascularization. Now coming to the management. So we can do optical correction, pharmacological control, and refractory surgery. Optical correction means we will give spectacles or contact lens, and with spectacles, concave or the minus lenses are given. We have to take care that we have to give minimum minus power for maximum visual acuity. Okay, minimum minus power for maximal visual acuity. If we will give maximum minus power, what happens? There will be artificial hypermetropia or accommodative strain. So we should give only minimum minus power for maximum visual acuity. Coming to the contact lenses, they are actually preferred in high myopia because contact lenses will give only minimum minification, and also peripheral aberrations will be less. Now coming to pharmacological control, that are low dose aspirin, 0.01% aspirin. This is usually given in children to retard the axial elongation. So in school myopias, it can retard the axial elongation. That is the pharmacological control. And the main thing is refractive surgery. So we can do corneal refractive surgery and lens based refractive surgery. Corneal refractive surgery is usually done to -8 to -10 diopter. For -8 diopter itself, we will do what? Corneal refractive surgery. Here actually we were flattening the cornea. Okay, we are flattening the cornea. There will be steeper cornea. So we will flatten this cornea. Okay, and this can be done by LASIK, SMILE, or PRK. What is LASIK? It is laser assisted in situ keratomileusis. It is a laser surgery. What is SMILE? It is small incision lenticule extraction. And then PRK. These are the corneal refractive surgery. Lens based refractive surgery are for even more higher myopia, that is more than -8 diopter, particularly up to 12 diopter and all. Here we will give phakic intraocular lenses or RLE. What is RLE? Refractive lens exchange. So these are the treatment of choice, and these are done in case of thin cornea. Because in corneal surgeries, we have to flatten the cornea. If the cornea is already thin, we cannot flatten the cornea. So we will do lens based refractive surgery. So this was all about myopia. Remember, you have to classify it as 5 headings and write definition, etiological classification, clinical types, clinical features, where we will write symptoms and signs. In signs, anterior segment and posterior segment sign, which are specific to the pathological myopia. Complications like retinal detachment, complicated cataract, vitreous hemorrhage, choroidal neovascularization, and management including optical correction, pharmacological correction, refractory correction, where refractive surgery include corneal and lens based refractive surgery. So this was all about myopia. Hope it was useful. Thank you.